Hi, friends. I'm Dana Lewison, therapist and founder of the Empowerment Collective.
And I am Dr. Roshni Patel. I'm a board certified OBGYN and the founder of Luminate Gynecology. And today we're talking about something that I did not realize more patients needed to understand until patients started asking me harder questions. And this is your heart health during perimenopause and menopause.
And the truth is, most women aren't asking those questions because we're taught not to.
So we invited an expert. We invited Dr. Amy Ahnert, director and extraordinaire cardiologist of the Women's Heart Program at Morristown Medical Center in New Jersey. And she's here to share all her knowledge and wisdom. She is a cardiologist that specializes in and cares about women and women's whole lives and not just their EKGs.
We're covering what you actually need to know about your cardiac risk, when to start paying attention, and the myths that are keeping you from taking your heart seriously. We are thrilled to have you, Dr. Honor. Welcome to No Sick Days.
Thank you for having me. I'm so excited to be here. So much we can talk about. So I'm just really excited about the opportunity.
Thank you. We are so thrilled to have you on. And we just want to share everything about you. Maybe you can walk us through a little bit like your journey to getting here and like how you decided to focus on women's heart health.
Sure. So I've been practicing as a cardiologist for over 20 years. And when I started my journey in cardiology, I was focused on being a general non-invasive cardiologist. So I took care of men, I took care of women, I took care of all ages and stages of patients' lives. And when I did my training in medical school and in residency and in fellowship where we specialize in cardiology, there was no training at all about women's heart health. There was no training about the differences between heart disease in women and heart disease in men. And it became really quickly apparent to me when I started practicing that we had so much lack of knowledge and understanding about the differences between men and women. Yet we were starting to learn about these significant disparities in heart disease between men and women, how women have different symptoms, how women have worse outcomes. And we were just starting to kind of scratch the surface. I was always really interested in taking care of women. So when I was in medical school, I loved OBGYN and I thought that I really wanted to do OBGYN. But Dr. Patel
Yeah.
did not really favor the hours. This is not for me. And so it's just so interesting for me how my career really came full circle, how I've now come back around to specializing and taking care of women. So through my years of practice, it really became a labor of love for me. It became my own kind of passion to focus and care for and treat women, both when we talk about prevention of heart disease, identification of heart disease, and treatment of heart disease. And we just needed to start to really get the message out that women are not just small men. And unfortunately, there's been such a lack of understanding of heart disease in women, a lack of research, a lack of attention, and the whole lack of awareness. So I really made it my mission and my calling to specialize in the care and treatment of women. I think what's also really fascinating looking back is in my journey, it was a fight. Like I had to continuously fight for my why among different places that I've practiced, from administrators saying, well, I don't understand. Like, why do you really need a women's heart program? What's really different about women? And I continuously over and over had to go to battle and fight to defend my why of why women deserved something different when it came to cardiovascular care. And still to this day, it's something that I often have to defend. But now I've come to a place where I've realized, and I'm proud to say, not only do I specialize in women's heart health, but I try to really provide something that is concrete and substantial. It's not just hanging up a shingle and saying, I'm a women cardiologist, so I take care of women. It's really about being intentional about developing programs for specific types of women, for specific ages of women, for specific diseases that affect women. Menopause being one of them, but there's many others across a woman's lifespan that we really need dedicated programs, and we need physicians and clinicians that really understand the differences between women if we're going to start moving the needle and making a difference and impacting heart disease in women. So what many women in this country still don't know is that heart disease is the number one killer of women. For 20 years, I've been going around and saying, heart disease is the number one killer of women. And we're just little by little by little trickling and getting that message out so that women can have a better understanding about what that really means.
It's
Amazing.
yeah,
Just
absolutely
love it.
incredible. Right. Really, here's your cape.
Done.
Yeah,
No
like
notes.
goodbye. Nice having you on the
That's
show.
correct.
No, it's amazing, and I think the one thing that jumps out from the work and that you're doing specifically that separates you from other cardiologists and also even women focused cardiologists is that you are treating the whole person. You're treating the whole woman. We talk about, mental health. You talked about
Mm.
obstetrics history. You talk about caregiving, looking at women after they've had babies, looking at them perimenopause, the menopause. And that is so different than a lot of other cardiologists, other doctors, other professionals. And, you've shared with us what has helped you make that decision and what has put you on that journey. Do you find that you're up against there's a lot of challenges out that you have to deal with or up against a lot of walls that you have to break through to do the work that you do?
There's so many challenges. I mean, there's so many challenges if you just start first with the most basic, which is that we lack research, right? So historically, women have been underrepresented in cardiovascular research trials. So we always thought in academics, well, we just can look at a bunch of men and we can look at outcomes or we can look at studies and then we can just extrapolate it to women. So one of the biggest challenges is just the lack of research. And the good news is that is changing. So there's in the medical community an increased awareness that that doesn't fly anymore and that we need to look specifically at women and study women if we're going to really understand the differences and the nuance of cardiovascular disease. I think the second big challenge is a lack of awareness even in the medical community. So many in the medical community still are not aware of the differences of heart disease between men and women. We can talk about the differences between men and women go across every single aspect of cardiovascular disease, really from soup to nuts. So when we think about symptoms of heart disease in women can and are often very different than men. So we have this picture in our brain of what heart disease looks like. And that is a middle-aged man with white hair clutching his chest to be white Caucasian and, and then everybody rushes around him and calls 911. Well, heart disease in women can be very different. It can be more subtle. It's not always the chest pain and the elephant on the chest. It can be unexplainable fatigue, unexplainable nausea. It can be shortness of breath. It can be sweating. It can be pain really anywhere. I always say from the top of the head to the middle of the belly. It can be in the back. It can be in the jaw. That is also a big challenge. It's a big challenge to even let alone patients, but also medical community to be more aware because we tend to underestimate and undertreat heart disease in women because it's not always on the top of mind, even in physicians. I think other challenges that we're facing is we really need more data to understand the differences in the risk factors in men versus women. And we're finally making some headway there, which is amazing. I mean, there's a lot of bright lights in what we're going to talk about today. There's a lot of depressing statistics. There's a lot of hope, right? So when you think about the statistics, so heart disease is the number one killer of women. One of the most scariest statistics is that heart disease is rising in young women. Yeah. The woman ages 35 to 54 is a cohort of women where we're seeing a rise in heart disease and heart disease deaths. That is super scary, right?
Yeah.
When we think about what that means for our future and how important it is that we have to start now with trying to reverse these trends. And part of why it is so challenging is because we've been missing the boat. We've been missing the opportunity of identifying young women at risk and what risk means and what risk factors they have and what we can do more importantly to prevent heart disease. So with that, I think many people in the community are pretty aware of what we call the traditional risk factors for heart disease. So people know, they know smoking is bad, right? They know high cholesterol, high blood pressure, diabetes, obesity. I mean, I think we've done a really good job of getting those messages across to patients, both men and women. But I think what many women don't know, and even many healthcare practitioners, is that there are many other risk factors that potentially can affect a woman. And what you were mentioning before is the interconnectedness of diseases in women, right? The mental health, the OBGYN, these things all together come together and can impact a woman's cardiovascular risk and cardiovascular health. So, what am I talking about? Pregnancy related complications. So, women who endure certain complications in pregnancy, like high blood pressure in pregnancy, preeclampsia, which is a severe form of high blood pressure in pregnancy, gestational diabetes, which is high blood sugar in pregnancy. We used to think that these were things that just affected a woman during a pregnancy. And once you were done, you delivered, you didn't have to worry about it. We've known for years that women who have experienced, especially preeclampsia, which again is a severe form of high blood pressure in pregnancy, that's a risk factor for them to develop cardiovascular disease. It actually made it into our heart guidelines back in 2011 that this is a risk
Yeah.
factor. Fast forward, we're in 2026 and not
And
much
still.
has changed to educate women about this, right? So women are having this something that happens in pregnancy actually is the beginning of a potential chronic condition.
Condition.
So we need to recognize and educate women about these other risk factors that are not necessarily known. And that's just one, mental health, right? So mental health, anxiety, PTSD, trauma. We know that these are risk factors, especially untreated depression, for the development of cardiovascular disease in women and many other gynecologic problems, which is why I work so closely with OBGYNs and with mental health providers, which is why I just love working with the two of you. Things like PCOS, which is polycystic ovarian syndrome. That's a risk factor for cardiovascular disease. Premature menopause is a risk factor for cardiovascular disease. Autoimmune conditions, things like lupus, rheumatoid arthritis. So there's this whole bucket of categories of ailments that can affect a woman that they may be walking around with, and no one's ever taken the time or opportunity to say, you know what? You're at risk. Let's talk about your risk. Let's talk about how to make you healthier. Let's talk about how to prevent heart disease. So the barriers that I face on a day-to-day basis in terms of trying to tip the needle and make a difference is honestly coming from all.
All sides. Yeah.
Yeah, it really is. But my true belief is that the most important way that we're going to make an impact is through conversations like this, right? It's education, it's awareness, it's empowerment. Women often are treated medically in silos of care, right? So they see
Yeah.
OBGYN and then they go see their internist and then maybe they come see their cardiologist and we have such a better opportunity to do better work and better care and better treatment of women if we can start connecting the dots and the different pieces that affect the whole woman. I'm not even sure what you asked me, but
Yeah.
That was it. No, you got that was, I think it was a great answer for what it is. You know,
question.
Roche and I talk about all the time putting together a team, right? We talk about
Hmm.
building your team. And I think you are such a, I want to say role model, right? For what it looks like, what that looks like in practice. Being able to say, this is what I do, and here's how I can connect it to other professions, other doctors, other professionals out there who we can look at the whole woman and not just I love that about looking at or each woman being seen by the silo of care as opposed to let's help connect those dots. And yeah,
Professionals that understand what I was talking about in the beginning about my own journey in my career professionally and how it felt many times like I had to prove myself and I had to defend.
Yeah.
Women needed a different model of care. But I truly feel that women do. They need to be seen, whether it's, an OBGYN, whether it's an internist, a primary care doc, a mental health provider, a cardiologist, someone who really truly understands what those differences are and what the interconnectedness is between all their different health problems. Because this is, I think, part of the reason why we're seeing this crisis in heart disease in women and especially in young
Young
women.
women.
So we have to think differently. We can't just go to the old playbook and think that what we've been doing is working because it's not. And part of it is awareness, and part of it is education, and part of it is just understanding and the research gaps that we talked about. And we certainly know that we have a lot of problems in society that are contributing to this. We have obesity, and we have inactivity, and we have unhealthy food, and we have a crisis of mental health, and highly stressed women who are out there trying to do it all. And the last thing they're thinking about is their heart health. Like I saw a quote, and I'll probably mess it up, but it was something like to women, it was like, do you clean your house? Yes. And like, it wasn't like, do you take a shower? But it was something like, do you, that you're like, yes, of course, of course. Like the last thing is, do you take care of your heart health? And the answer is probably not, right? So because it's just not something that we think about. And as women, we're thinking about everybody else first, and we're prioritizing ourselves last. And we have to flip that on its head, especially if we're going to make inroads into decreasing cardiovascular disease.
Yeah. So many things, so many places we could go with that. I'll take a step back though. We were mentioned like heart disease is the number one killer of women. And it's when I see patients, because of how healthcare is now, sometimes I'm like the quarterback and I'm like, did you see your GI? Did you do this? Did you, cause they don't have high quality primary care, which is a whole other, bag of worms. But I'll tell them, like, sometimes women will look at me funny when I'm like, have you seen a cardiologist? They're like, well, I go for my mammogram. And I'm like, how did mammogram or breast health, which is important, I'm not gonna dismiss it ever, but I'm so interested in how like breast cancer awareness and breast cancer screening is like the up here, where in fact like data, numbers, statistics tell us that heart disease is the number one killer. Like, how did it happen? And even like, menopause is like having its moment. Menopause is not new. It is literally probably the oldest thing next to pregnancy, right? Like, I don't know which one they figured out first, but like I'm curious about your thoughts on that. How the branding, societal messaging, I don't know, maybe it's like Susan G. Komen's advertisement power is more powerful than heart health. And like heart health isn't sexy. I don't know.
No, I think it's such a fascinating question. And anytime I give a talk in the community about heart health in women, I talk about this. And I talk about the fact that heart disease, as we said, is the number one killer of women, and it kills more women than all forms of cancer combined. So much higher
Yep.
than breast cancer and more than all forms of cancer combined. And I always say, it doesn't mean we stop getting our mammograms, right? We still get our mammograms, and our mammograms are really important, but we can't think about the cardiovascular health. When I think about it, I think why? Like, why have we not been effective in getting that messaging out? And I think part of it is that the cancer societies have done a really good job. Like, I think they've done a really good job with raising this to our consciousness in women, that this is something that we have to do, and we have to think about breast cancer. I also wonder if it's because it's a more simple paradigm. It's a more simple ask. It's breast cancer, mammogram. Mammogram detects breast cancer, right? There's just a very straightforward message and a very simple thing to ask women and healthcare providers to do. And then we think about heart disease. And I think one of the issues, as we talked about earlier, is the messaging from heart societies, American Heart Society, and others has been that picture of the man holding his chest. Now, the Go Red movement, which is a movement within the American Heart Association, which has been a real mover and shaker in terms of trying to increase awareness of heart disease in women. And that whole sect and the picture of the red dress, it's definitely having more of an impact on us in terms of thinking about the importance of heart disease. But I think it's just because it's not simple, right? Again, we have mammogram breast cancer. When you think about heart disease, there's so many different types of heart disease. What does heart disease even mean, right? I mean, I think sometimes people are like, I don't know, I think I have heart disease, or I think my mom has heart disease, but I don't really know what heart disease even is. And heart disease is a big umbrella that has many different subsets and categories. Often when we say the word heart disease, people think about coronary artery disease.
Mm-hmm.
So we can do a brief anatomy lesson, but essentially the heart's a big muscle, and its job is to pump. It also has its own circulation and its blood vessels that bring blood to the heart so that it can function. And those arteries are, if they get blocked with cholesterol or other that can cause blockages, which can cause heart attacks. So a lot of times when we think heart disease, that's what we're thinking. And there's ways to go about screening for coronary artery disease. There's also other forms of heart disease, things like heart failure, where the heart can get weak or enlarged, valve problems in the heart called valvular heart disease. There's heart rhythm problems, which are arrhythmias or electrical short circuits. So it's not so simple, right? It's not so simple to just say, oh, you need to go get screened for heart disease. Because number one, what does that even mean? Even from a cardiologist who specializes in heart disease in women, if we are to say, well, how do you screen a patient for heart disease? There's not one answer to that, right? There's many, it has to be individualized. It has to be personalized. You have to take into account the whole patient, all the risk factors, all the history, all the things we talked about for the non-traditional risk factors, and then decide how to screen. Is it blood work? Is it imaging? What else do we have to do? So I think part of the reason that maybe the breast cancer fear is on the top of women's minds and not the heart disease fear is because the messaging and the lack of clarity and somewhat kind of confusion as to what that even means.
Yeah. That makes sense to me. I mean, it's diagnostically not straightforward, right? Like it's like you said, there's a lot more workup, time, patience, energy, nuance, right? Is exactly why menopause care is not straightforward, right? Pap smear is another great example. We all like, I get my pap smear, blah, 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 because it's easy. Pap smear, cervical cancer,
Very
Um,
literal. Like every woman should get a mammogram. Okay, but it's not so straightforward when you look at even like the prevention guidelines as it relates to screening for cardiovascular disease and proper preventions and when to initiate medications. And we've made it very, very complicated, I think, in many ways. I try to make things much more simple with my patients, but I do think that that's one of the reasons why we're not really getting to all the women that need to be screened for cardiovascular disease because it's just not as straightforward.
So, for the women who are listening right now, right, they're probably managing their kids, their career, their marriage, perimenopause stuff. My heart is beating faster since you went through all those conditions myself. So, when should we start paying better
yeah,
attention to
asking
our
for a friend.
hearts? Right, not for a friend. This is straight up for me. I will own this one, everybody. So, when do we start paying attention more? When do we start asking our doctor versus when do we see a cardiologist? When do we go to you and really start taking it more seriously? Should we do that in our 30s? Should we do that in our 40s? When do we start paying attention?
Yeah, and my answer to that is childhood.
Okay,
Okay.
fair. Geez, so I'm late now.
Yeah, that's
That's what
okay.
you're telling me. Great, fantastic.
Childhood, adolescence, young adulthood. I mean, if we really want to think about prevention, as moms, when we have young kids, that's the time to start thinking about prevention. That's the time that we have to start thinking about healthy habits for our kids. That's the time we have to start thinking about introducing them to healthy eating, to exercise, to minimizing screen time, to making social connections. All of these things that we know are so important. We have to start when they're kids. I always say you're never too young and you're never too old to think about cardiovascular disease risk reduction. So I think what we're seeing now with obesity in our kids, with depression, with just
Screens. Ugh.
screen time and the social media, I mean, it is so scary that the statistics that I talked about earlier scares me to death to think about what that's going to look like in the next 10 to 15 years because we are not necessarily starting young enough to make sure that our kids are leading heart healthy lives. I think then there are different times in a woman's health in a woman's life that are really important. And we now look at those as important opportunities of when they should be identified and coming under care. I'm not necessarily saying cardiovascular care, but before pregnancy, right? So before pregnancy is such an important period of time in a woman's heart health, not even in their obstetric health. So getting as healthy as possible prior to pregnancy is a stress test. Like it literally is a stress test. When you think about a stress test, we think in cardiology, it's like getting someone on the treadmill. You get someone on a treadmill and they're on the treadmill for 7 or 10 minutes. But pregnancy is literally a stress test that lasts
40 weeks.
40 weeks, which we always,
And then you have the baby.
I've never understood why we say 9 months, because to me,
I know.
4, 10, whatever.
Yeah,
But
I
that's
know. I'm with you. I'm with you.
always been really confusing, but also okay, fine. And that is a time where it can really bring out underlying cardiovascular conditions, and women are going into pregnancy. If you look at outcomes in pregnancy, we're seeing a massive rise in preeclampsia. We talked about preeclampsia earlier. We literally have an epidemic of preeclampsia. We're seeing numbers. I mean, a lot of the statistics are saying, 10%, 15%. I think
More.
it's higher. I think it's closer to 15 to 20%. Part of the reason why is because women are entering pregnancy. They've done studies. Less than 1 in 10 women that are of pregnancy age have ideal cardiovascular health in our country, meaning like they move, they exercise, they eat healthy, they don't smoke, like all of those things. So pregnancy is a really high risk time that we want to make sure that we're focusing on getting women healthy before, during, and after. So after pregnancy, if we've identified some of these risk factors, if we've seen that a patient's had high blood pressure, preeclampsia, gestational diabetes, that's the time we have to get them in to intervene, because we're missing the opportunity to educate them, talk to them about heart healthy living, talk to them about screening, talk to them about how do I even think about being healthy? How do I even think about prevention? How do I even think about eating well and exercising? Baby at home. I have a newborn, and maybe I just had preeclampsia, by the way, and I had a preterm birth and my blood pressure's off the roof, and I'm thinking about everybody. I'm not sleeping. Like, it's really hard, right? But it's the time where we have to be able to capture these women to talk about their risk. And when we think about the journey, so 20s and 30s absolutely are times when we want to be thinking about prevention. We want to be getting heart healthy checkups. What does that mean? Making sure you're having your blood pressure checked and your cholesterol checked and your sugar checked, and that you're meeting with a doctor who's going to be able to tailor kind of heart healthy lifestyle interventions for you. How do you get your exercise? How can we improve your diet? What I feel really passionately about also is, I think, especially for women, the reason we do such a disservice is we just say, just go exercise, go eat healthy. Like, what does it mean?
What does it mean,
Yeah.
right?
So meaningless and infuriating, I think, because who has the time?
Yeah.
What I try to do with my patients, again, is be really individual and personal and say, what's your lifestyle like? What time are you getting up in the morning? What time do you have to put the kids in the bed, on the bus? What time are you going to bed? How can we kind of create 10 minutes? Like, if you can get 10 minutes of exercise, if you can get 10 minutes to dedicate to yourself, or, when the kids are doing their homework, or just really, and how do you eat healthy? What does that mean? What do you shop for? What do you buy? How can you try to make things that are going to be easy, quick, and healthy and nutritious? So part of like a heart healthy checkup is not only checking your numbers, but it's seeing someone who can help you to make sure that you're doing all the lifestyle things that you can do to keep your heart healthy. And then as we progress into our 40s and 50s, yet again, that becomes another really important time of life where we need to be continuing to look at those same things, those risk factors, the cholesterol, the blood pressure, the sugar, the lifestyle. So we got to start young. I think if anything, I wouldn't even say, oh, it's by this age or by that age. We just have to start with heart healthy living as young as we can, because that's going to translate into decreasing the risk of cardiovascular disease. And I don't think I said this yet, which is really important, or maybe I did. Heart disease is preventable, right? So heart disease is preventable, most heart disease. And many of the things that we can do to prevent, we can do by trying to make changes within our own lives and how we live. Not that it's easy, but we can have control over many of our lifestyle choices that can translate into prevention of heart disease. So it's not an inevitability. And that's the good news.
Yeah. That's huge. Leaning into that, decades of life and journeys of health, like as we approach perimenopause and menopause, and now kind of hormone therapies getting more airplay, there is sometimes these conversations like, oh, I can't go on hormone therapy because it causes cancer, or I can't go on hormone therapy because I'll throw a clot. What are some of the ways that you talk to patients, or what do you want women to know about the intersection of menopause and cardiac risk? Natural menopause, because surgical menopause, I would say, is a whole other bag of tricks.
Yeah, and it's so important. So we talked about all of these really important stages in a woman's life where potential risk increases or becomes more apparent, like pregnancy. But menopause is another time of life where we do see an increased risk of cardiovascular disease. So that's number one. It's really important for women to know that. And again, getting to a little basic pathophysiology of the why. So during menopause, we lose our estrogen. And when you look at all the changes that can occur and do occur in a woman's body during the time of menopause, mostly because of the lack and loss of estrogen, and you put it on a chart, all of those things are not good for cardiovascular disease. So let's talk about it. So we have increasing blood pressure that can happen during the time of menopause, weight gain, metabolic syndromes, which are kind of increasing sugar, increasing cholesterol. We have a lack of sleep. We know that sleep is really important for cardiovascular disease prevention. We have irritability and the hot flashes. And we know that that also has been shown to increase the risk of cardiovascular disease. And we also see that women's arteries can get more stiff. So stiffening of arteries and all of those other things that we talked about. Well, if you add them up, it's no wonder that women would be at higher risk of cardiovascular disease. If we're gaining weight, our blood pressure is going up, our cholesterol is going up, we're not sleeping, we're sweating, we're miserable, we're angry. I mean, hello.
Yeah.
And I didn't do my disclosures, but my disclosures are that I am a perimenopausal woman.
Yeah, we all are in the
there,
club.
yeah.
We're all sweating. Now I'm freaking out about my heart, but it's preventable.
No,
So
we're going to
I'll be okay. We are going to, I'm just going to throw this in here too. We are going to add your information to this podcast as well. So people can contact you,
Come
ask
see
more
you as
questions,
patients. Yep.
right. Come make appointments with you and see you directly so that you can take care of them and make sure that my heart is okay.
Yeah. Yes. We got you. We got you.
So experience healthcare the way it should be. Just plugging that in there.
Yes.
Yes.
Absolutely. So I'm experiencing it. So I'm surviving it. But I think where menopause, as you said, menopause is having its moment now. And for good reason. I mean, I'm glad. Listen, we're talking about it.
Yeah.
I'm talking about something that women have suffered with, and at least it's forcing the conversation. It's increasing the awareness. And I think the trickle down effect for me is that, well, as we're talking about menopause and we're talking about the possibility of thinking about hormone replacement therapy, that is leading us to increasing the conversation about heart disease. So that's a big silver lining for me in terms of that this is getting so much airtime and, so much exposure out in culture and society. When it comes to then if all those things are bad for heart disease, and then, well, doesn't it make sense that then we should be able to put all women on hormones? And if we put them on hormones, then we're going to be able to prevent heart disease. And it makes sense. But the proof is always in the pudding. And this is really where we fall short. So when I have many women who come and see me to talk about, well, what are the risks of me going on hormones? Is it safe from a cardiovascular standpoint? And historically, many, many years ago, we gave hormones to all women after menopause. We're like, here, take a pill, take a pill, take a pill. And we honestly, the healthcare profession thought that we were doing great things. Like we thought we were preventing heart disease and we were keeping women alive longer and healthier. And then there was a study that was done in the 1990s called the Women's Health Initiative that basically said, oh no, like we're giving hormones and we're actually increasing the risk of heart disease and breast cancer and clots, and took it all away. Many years have gone by and there's now been this retrospectoscope saying, ooh, you know what? The study didn't really answer the question. The study was flawed. The study didn't look at the right patients, the right doses, the right formulations. So essentially, the stones that have been thrown at those studies were to say, well, if you take women and you give them hormones at older ages, when maybe they've already developed heart disease and other risk factors, well, then maybe the hormones are going to be detrimental. And we also were giving certain types of formulations that we don't give anymore. So now with newer formulations, the thought process has changed. Well, maybe if we narrow down the woman that we're thinking about giving hormones to, and instead the current thought is that, well, younger patients, in other words, patients that are closer to menopause, who are symptomatic within 10 years of menopause and less than 60, 65 years old. As well, those are patients that should be at lower risk of having cardiovascular complications. But should is the important word there. And we still have to be careful and tread lightly. My mantra with anything as it relates to taking care of women is it has to be individualized, it has to be personalized. There's not a one size fits all. I mean, and that is the most important message. Just because your friend and sister or someone else is on hormones and doing great, it doesn't mean it's necessarily right for you. It may be, but we really have to make sure that there are no significant high risk, like you haven't had a heart attack, haven't had a stroke, have other high risk for breast cancer. We haven't had a new study that has come out and said, this is actually great. We're going to prevent heart disease. And this is where, when I said the proof is in the pudding, in medicine, we like data and science to prove that something works. It makes sense. I think it makes sense. Intuitively, to me, it makes sense. Loss of estrogen causing all these bad things, replace estrogen, all those things should get better. So we should be able to help decrease and prevent cardiovascular disease. It makes sense. But we've been burned before in medicine when things have made sense, but we haven't had the data and the science and the studies to prove it. So my job when patients come to see me is just to try to help individualize and make sure that I don't think the hormones are going to be high risk for them. If they have risk factors for heart disease, I think it's a great opportunity, right? Because what I look at it is they're coming and they're saying, I want hormones. And I'm like, okay, let's look at you. Let's look at your entire risk profile. Your cholesterol's a little high and your weight's a little high and your blood pressure's a little borderline and you're not doing a great job with a heart healthy diet. Let's let's make a compromise. Let's agree that, yes, I think hormones are okay, but let's work on those other things. Let's make sure we're actually treating your cholesterol and talking about weight loss management and talking about healthy eating so that I'm not necessarily depriving them of something that I think may be beneficial, again, operative word, but we're also not just giving it willy nilly and ignoring the opportunity to talk about all those other things that are really important for prevention. So I agree. I think that we just need to tread lightly. I'm glad we're having the conversation and I'm glad that we're talking about this really important thing that many women were gaslighted and told just to suffer through.
Yeah.
But we just need to make sure that we are individualizing and making sure that things are safe.
I like it.
Is that what
Such
you agree with that?
Yeah, and that's what I do. I'm on the other side when they're like, "Oh, yeah, I heard so and so's on hormone therapy, and I saw blah blah documentary, and I want the patch." I'm like, "Okay, when's your last lipid profile? When's your A1C? Because you're not getting a patch from me until we talk about. I'm not just gonna give, And I say it nicely, obviously. It's Friday afternoon, guys. Mommy's had a week,
right.
But it
but
is
we,
important to check those
yeah,
things and to check,
yeah,
and sometimes I might check other tests, right? So that's what's so important to really understand. I'm going to talk to a woman, and when I look at their risk factors, it's not
yeah.
going to be just was like, do you have a high blood pressure? What's your cholesterol? It's going to be, have you had a history of polycystic ovarian syndrome? Have you had a history of preeclampsia? Did you have gestational diabetes? Do you have autoimmune disease? Considering other blood tests that we now look at as these tiebreakers for when to intervene and treat cholesterol. So
Mhm.
there's a lot of talk right now about a blood test called LP little a or lipoprotein little a. So it is a particle that's in our blood that we know when it's high, it can increase the risk of cardiovascular disease. And we don't have medications currently to treat it and lower it, but it is known to increase risk. So if I see that's really high, then that may be a reason that I would think about starting a patient on medications for their cholesterol as opposed to if it weren't, or checking a calcium score. So a lot of women out in the community now are aware of this. Oh, what's your, everybody's like
Yeah.
competitive. Like, what's your number? Well, what's the
Did you get
calcium?
it done? Yeah.
I've actually never had my own done, but maybe the three of us can go out and we can get calcium scores together.
Oh my God. Yes.
So very telling. That shows us underneath the surface. That says, is there calcium or is there plaque in the arteries, and gives additional information when we're trying to know the patient in front of us. What is their risk, whether it's hormones or anything else, or do they need medications? All this information is complementary to be able to help us to really get a full sense of what potential risks and benefits are, especially as it relates to hormones.
Yeah. And sometimes patients don't know, right? Like if you ask, it's reasonable for me to ask patients about their obstetrical history. Like, oh, did you have preeclampsia, right? Like, yes, I'm going to ask. And they'll be like, oh no, I was fine. I'm like, I will ask in other ways. Did you have problems with your blood pressure? Did you leave the hospital when the baby left? Did you deliver? There's like other, kind of you have to beat around the bush, so to speak. And then speaking to the point about nuance, I'll just drop this here, is and you probably know more about this than I do, is there is something to be said about, I don't want to use the word racial, but South Asian health, because I talk about this in my own community. I think the numbers should be different for South Asian people. I think our A1C threshold should be lower. I think our LDL threshold should be lower because heart disease is a killer in our community. And then, I used to call them my sweet ladies. A lot of my OB patients were gestational diabetic because culturally how we eat. And then I'm not going to go tell them, if you're a vegetarian, oh, just go eat protein. No, that's not solving, anything. Like, to your point, medicine needs to be individualized. The history taking needs to be individualized, and a treatment path needs to be individualized. And now I'll get off my
I'm
soapbox.
glad you raised that though, because we talk about disparities and outcomes between men and women and how different they are. I mean, if women have worse outcomes, by the way, when they are afflicted by heart disease, look at those. Like, women are more likely to die after a heart attack. They're more likely to develop congestive heart failure. There's so many ways that the outcomes are worse in women versus men. But then if you look even among women, there's significant disparities among women. So all the things we talked about today, we talked about risk of preeclampsia, we talked about risk of heart disease. We didn't even talk about maternal mortality, which is another thing we can talk about, which is another really shocking statistic. So maternal mortality are moms that die soon, during, or after pregnancy. And the US has the highest maternal
Highest.
mortality rate of any developed nation. Where I practice in New Jersey, we're usually number 4 and number 5 in the nation. So it is a massive problem. And heart disease and preeclampsia and high blood pressure in pregnancy are major contributors to moms dying. So these are really awful things. But when you even look within those categories of patients, there's such disparities. So African American women, usually across the board, have 3 times, like the number I always tell patients, just think of three times increased risk of preeclampsia, 3 times increased risk of maternal mortality, significantly increased risk of cardiovascular disease, heart attack, strokes. So I'm so glad we're talking about this to educate women about heart disease and risk factors and signs and symptoms, and the importance of hopefully advocating for themselves and seeking out healthcare professionals that understand the differences. But we have even a bigger job to do if we want to start breaking down the racial disparities, which are just staggering.
Absolutely. And there's so much gaslighting within the industry and women not being heard, especially within, women of color and in the African American community. So I'm not shocked that statistically they'd be, more at risk and higher mortality rates, et cetera. We are going to have to do a part 2 with you because again, there's so many more questions. You have amazing information to share. I think this is so helpful for our listeners. But one last question to kind of sum it up for at least our part 1 of today. If you could tell every woman who is listening right now one thing about her heart, and something, if you could sit down with them, all the listeners are in a room. Just kidding. They couldn't fit in a room, you guys. They were all in a massive hotel, and you could tell them one important thing that they need to know about their heart or something about their heart. What would it be?
So I think the most important thing, and it's going to reiterate some of the things that we already said, which is women need to know that heart disease is their number 1 threat. They need to know that heart disease is preventable, and they need to know their own personal and individualized risk. So they need to see healthcare providers who are going to ask those questions to fully understand what are their numbers, what are their risk factors, what are the symptoms and signs that they need to look for, and what can they do personally and individually to prevent heart disease. Knowledge is power, and women need to be treated in a different way where we're no longer looking at this narrow lens. We have to broaden our lens as healthcare providers when we're treating women and taking care of women. So if anything, it's to empower them to share this message with other women in their lives so that women can start not missing that opportunity of how and when to prevent heart disease for themselves and for their loved ones and their friends and family members.
We got
Thank
work
you.
to do.
Yeah, exactly.
Actually, we lied. One more real question.
Oh my God.
Yes.
So we talked this has been a pleasure to have you on, and it's just fun and engaging and just also fills my cup about we have to keep fighting the good fight. But we don't even exist in a bubble, right? Like you're a woman in this world living on earth and you have children and a job and a career and a home and a family. How do you do it? Like, how do you handle no sick days? Your no sick days. Right now, I have one kid at home downstairs screaming. I don't know what's happening. I have no
Awesome.
idea. But we're just gonna leave him alone for a little while. Like, so how do you do it? How do you do it? How do you be the director of your own department and do all these fabulous things and just share your wisdom?
Oh, no. No, I'm kidding. No, the question makes me really reflect. And when I was talking in the beginning about my journey throughout my career and my profession, and it's changed at different times in my career. So I have 3 kids and I have a husband and I have a career and I have family and all these other things that so many of us as women have a million different hats that we wear during the day. I think early on in my career, it was really hard. Like I always described it as like this second arrow. So like my kids had things or stuff at school, or I was really always trying to make sure that I prioritized my own physical and mental health. But then I had this horrible guilt. So the second arrow was this guilt of like, I'm walking out, mommy's going to yoga and the kids are screaming, Mom! And I'm crying on the way to yoga. And I'm like, I'm the worst human being. I'm the worst mom. I'm terrible. I'm awful. And now I fast forward to my kids are older. So my kids now are 22, 20, and 16. And they now go to yoga, right? Like they now prioritize exercise and they'll tell me now that they appreciated me showing them, trying to show balance and role modeling for them, even though I felt so guilty. And I think it's ebbed and flowed, and there's times where I have better self-care and there's times where I don't have great self-care. Unfortunately, I'm in one of those right now. So
Yeah.
for me, and, I've been really lucky and blessed, and I'm so thankful that I have a really awesome partner. Like I have a husband who is a partner, and he does everything to try to help me to be my best and to lift me up and to keep me on my path. And when I start going dark, he's like, "No, come back to the bright side."
Come back.
And
See the light.
friends and family and a husband, and I'm lucky, and not everybody has those things. I've always really strived for balance, although there are times when the balance just totally swings off. And for me, that balance has tried to come into the form of exercise, yoga, mindfulness. Those have been really important to me for many years and really help, even if it's like for 10 minutes. And I have to remind literally, like, I have to remind myself of that. I need to remind myself, like, you need to take 10 minutes for yourself when you get home and put on a yoga video. And things are so much more accessible to us now too, right? Because we have yoga videos and we don't have to necessarily drive to the yoga studio like I
Yep.
used to when the kids were screaming and crying, holding my leg. But it's hard. It's hard to keep all of those hats. But I do strongly feel if we can find as women to get that little bit of time for ourselves, whether it's yoga or exercise or chatting with a friend or going for a walk or reading, whatever it is that you do, like
Yes.
finding those little bits of time, it only makes me better in my profession. Like when I get so burnt out where I'm like off the charts, it affects how I'm going to behave how I'm
Yeah.
going to show up at work. Like I can't show up at work in a bad mood and not caring because I care about my patients and I'm there to help them. And so it's actually really important for me if I can find those nuggets of time in my life and my day, even if it's 10 minutes or 5 minutes for my own self-care, and then I'm going to be better as a professional. It's funny because I've always said to women in particular, it is not selfish to take care of yourself. To say it over and over. It's not selfish to take care of yourself. You have to take care of yourself. If you don't take care of yourself, you're not going to be able to take care of all those around you. And I'm really good at giving that advice. And sometimes I'm good at taking
Taking
it,
it. Yep.
and sometimes I'm not.
Yeah.
And need to continue. Listen, we're in this journey of life, and I need to constantly remind myself and sometimes claw myself back to trying to find that little bit of balance and lack of guilt and setting boundaries. I think that's the other part about like the no sick days concept, which I just love that concept, is we're not proud of taking sick days. Like we feel like
Yeah.
failure if we've taken sick days. Like I should be able to show up
Power
no
through. Yeah.
matter what. But that's only a detriment to ourselves and to everybody else around us, whether it's personally or professionally. So, and I'm learning too. Like, I'm in this constant learning of, like, my husband tells me all the time, like, stop saying yes.
Yes. No.
We had
You
the
guys
same fight
know that.
yesterday. Yeah.
But and trying to, like, set more boundaries, but it's hard. And I think depending on the phases and stages of our lives and how old our kids are and what else we're getting thrown at us, I think I'm just starting to realize that even if I have no time, I can try to make 5 or 10 minutes. And that's going to help me to then not struggle with tremendous guilt that I have at different stages in my life. But we have
Yeah.
to unite together, right? As women, like, we have to say, no, we can take a sick day. Like,
Yes.
and sorry, my family needs me, or my friends need me, or I need me,
Yeah.
because we give so much for everybody else, and we are so often overachieving anyway, and we just have to find a way to kind of support ourselves that it's okay.
Love it.
Absolutely.
Thank
I mean,
you.
we have to shift the paradigm, right? That's such a beautiful reminder of taking that time for yourself, that even when your children are upset, that they are watching and you are modeling that behavior and they
Yeah.
are watching and they are following it. And as they get older, they will forgive you, even when they're, like you said, screaming and
Yeah.
holding on to your foot. But it is so important that we all do that. We're really good at white knuckling things, but you don't. So thank you for that reminder. It
Yes.
has been so good to have you on.
Yes.
As I said, we're going to do a part 2. We are also going to link all of your information below.
Yes.
But until then, I know we
Yeah.
all have to get back to work,
Yeah.
because when you are doing it all, there are really
No sick days.
sick days, y'all. Thanks for listening, everyone. Dr. Ahnert, thanks for being here.
Thank
Thank
you.
you very much. Thank you.
No Sick Days is for information and education only. It is not medical or mental health treatment. Listening to this podcast does not create a medical or therapeutic relationship. Please talk to a qualified professional for care that is right for you.